Yes, please pass my regards to him.
I will, I promise.
We have a great talk from Professor Reza Shadmer. Actually, he is one of the probably pioneer on human-machine interface. I will invite him to also give a talk so that I right away think about Dr. Liu. I'm seeing that everybody that are joining, we are just at 10 a.m. Central, as well as 8 a.m. Pacific time. Good morning, everyone. Welcome to another C2SHiP Think Tank Friday meeting. I'm pleased to actually present C2SHiP and also great speaker that we have, Dr. Malindu Fernando. Just a minute that I can present him. But before that, I would like to, I'm guessing I have sharing the wrong file. I share the right file. Okay.
Bijan, your head has disappeared and I feel completely unmoored. My Friday. Oh, there you're back. Oh, thank God you're back.
Yes,
okay.
Yes. I open up so many files and I have a little technical difficulty, but just bear with me in a second. So hopefully I can reconnect to the slides. So just a minute.
Try shaking the machine. Shaking the machine.
That's true. It's good.
What I learned from last week is it could be the gyroscope in the device that might help it work well, or the magnetometer.
Yes, exactly. So just a minute. I don't know what's going on with my computer. It seems that the vacation that I had last week is messed up with many things. So here we go. I open the file and hopefully it should be work now. Okay, here we go. So can you see the screen? There you go. That's great. So we have a great speaker, Dr. Malindu Fernando, that I will introduce in a minute. He will, okay, it seems that there is a, again, is it okay? Because I have some strange difficulty.
Have not seen your screen, but,
yes,
that's fine.
I think it seems exactly. It seems that we're all having and sharing your strange difficulty, but it's kind of fun. So keep going, Professor Najafi.
Sorry, I don't know what's going on with my computer. This is the first time that's happening, it seems. Let's try again.
Oh, Bijan, do you want to just briefly introduce what IUCRC is without the slides, and then we go around?
Yes, I will do. I try one more time, and then if it doesn't work, I will try. So again, today we have a great speaker or Fulbright scholar that I will explain in a minute. But for introduction of the C2SHiP, because every time we have some new guests who give a brief introduction what C2SHiP is about. So C2SHiP is really a center that I always say that our logo is colorful because actually there's a reason. There are more 5 academic institutions, including University of Arizona, Baylor, University of Southern California, Caltech.
I think we also have a little bit of a connection issue with
we have a connection. I don't know. It seemed that it's a start to remove them, but I will talk without sharing the slide. So actually, about one of the focus of the center that we have is to promote decentralized care delivery model to help to bring care that is currently centered on the hospital, to bring the care around the patient home or any location that the patient are active. We brought multiple institutions who share the experience to make this model happen. Every Friday, we have a weekly meeting, and the idea of this weekly meeting is to foster collaboration. Often we have the presenter from industries that will talk about the innovative work that they are doing and the need that they have, that industry can help to address them. Or we have the presenter from the academia that talk about the innovative works that they are doing and the needs that we have in the field. Often we are seeing that research is maybe some may consider from bench to bed, but sometimes the research can be from bed to bench. Sometimes the doctors also can see the problem that we have in clinical fields, and engineers, the scientists can find out that how they can address the problem. And actually a speaker today will talk about bedside idea, a problem that hopefully can bring to bench and address them. Just for next week, an announcement. I'm scared to actually share my screen to cause again another problem. But thanks to Dr. Gozani, or IAB member, we have a great speaker from FDA, Dr. John Doucette, that will talk about FDA Breakthrough Device Program. All the industries and also scientists that want to hear about FDA breakthrough, because it's quite new, but it could be a very simple way for scientists to bring their products to the market. You may note your agenda and attend our next week talk and listen to Dr. John Doucette. I know that it seems that they work several industries to help to get FDA breakthrough for their device. I'm hoping that Shai can present soon. But without further ado, I would like to go to our center directors to see that whether they have any updates that they want to share. First, starting from Professor Janet Roveda, the center director at the University of Arizona.
Thank you, Bishan. So I think at this point, we collected enough member, and that we're waiting for money to come in. Because we do need to go above 600K by the end of April. But we're hopeful because all the money are coming in every day. We see some. Okay, I'm still working on it. And then the moment we reach the red tape, I'm going to send everybody a email. Just congratulate milestone year 1. Okay, so that's on my end. But I also would like to introduce quickly Professor Sawyer from University UC San Francisco. She's just joined us today. Okay, Professor Sawyer, do you want to say a couple words?
Well, hi, thank you very much. It's an honor to be invited or to be allowed in at my own invitation, I guess. I'm very interested in your work. I think it aligns very closely with what I do clinically in trying to create distributed care models. My clinical work right now is orthopedics and particularly skeletal health, but I do a lot of remote and distributed medical care on Earth and in space medicine.
Thank you.
We are great honor to have you actually at our C2SHiP meeting. So very soon we'll have a chat during our leadership meeting to discuss and hopefully bring UC San Francisco as one of the member of the C2SHiP. Actually, from UC San Francisco, we have another great physician, Professor David Klonoff, that joined us as well.
Fantastic.
Dave Klonoff, are you there? Oh my God.
Hi, yes.
It's like old homework. All right.
Well,
wow.
I'm really interested in what you're doing, and I'm hoping to be involved in some way, maybe sign up to volunteer with one of your centers. I'm president of Diabetes Technology Society, clinical professor of medicine, UC San Francisco, editor of Journal of Diabetes Science and Technology, and you've got an amazing team.
Thank you so much, David. It's a great honor to have that amazing scientist as part of the C2SHiP. Again, it's all about partnership. And there are a lot that we can do. There are a lot of problems that we have in current care delivery model that can be changed by fostering interdisciplinary collaboration. Next, I'm seeing Professor Chiara Dario, the center director from Caltech.
Is she walking?
Yes.
Oh,
Good morning, everybody.
There she is. Yeah.
I have no major updates on our part, so I'm just looking forward to hearing the talk this week and next week.
Thank you, Chiara. And Professor David Armstrong, my great mentor.
Yeah. Well, hello everyone, and it's been an eventful week. But it's great to see Doc. Not only Klonoff, God, that's great, but Dr. Sawyer. One of my old friends is Peter Kavanagh, and Peter used to run the bone loss unit forever on the space station. So to see you here talking about skeletal health, or skeletal health, as he would say, is absolutely terrific, and it's just going to fit so well with a lot of the stuff we're doing. So to everyone, we had an eventful week, met with a bunch of people, most notably a couple of days ago, Wei Gao came over. I know Kiara knows this. I texted her and we talked epidermal electronics collaborations. And I think there's a lot of stuff that's going to be happening immediately. There's a flurry of emails, and I think that's going to boost a lot of the projects we're doing in C2SHiP and create a bunch of new ones. Stay tuned on that. More to come.
Yes, exactly. Actually, we are also negotiating with a couple of other industries that are interested to join us. Thanks to Margaret as well as Dr. Gozani to introduce them to us. Is amazing. And we'll hear about those new companies as well. Dr. Skubik, Center Director from University of Missouri.
Hello, everyone. I don't really have any updates today. I'm just looking forward to the talk, and it's always good to see everyone.
And I'm guessing Kuyar, Potential Center Director from University of North Dakota. Kuyar, do you want to share any updates?
Good morning, everybody. I have a very short update. I'm working with Wound Exam. We will be submitting an STTR grant on April 5th. I don't think their check will come by the end of April, but they would be the first company from my side that they will be joining C2SHiP, and I'm working with 2 others, hopefully coming after.
Amazing, amazing.
Outstanding.
I'm very soon, actually, thanks to Margaret, we may also talk to another institution, is Mehari from Nashville. And that would be great to have this geography diversity from all the United States to join us to build infrastructure to help industry. So with that, I would like to go to our IB chair and co-chair, Margaret and Shai. Margaret, do you have any update to share?
No, just to say, it's the easiest thing to do is to talk about C2SHiP, but it seems like a majority of my conversations in the last 2-3 weeks has been involved in directing people to the center with a lot of excitement. So I'm very excited about the near future.
Thank you so much. It's great to see that our industrial members are advocating for C2SHiP and bringing additional members. That is amazing. Thank you so much. I don't know that Shai, whether he's in the call or not. But Shai, actually, he generously also connects us with several people, including the speaker next week that will talk about FDA breakthrough. So I'm seeing Drew from NSF also is on the call. Drew, do you want to share anything? I don't know, Drew, is me or I couldn't hear you.
I can feel him spiritually. It's a strong spiritual presence.
How's that?
Yes.
Oh, wow!
Ah.
There it was. I felt it coming.
Okay. A miscommunication between my Zoom mute and my audio device. So anyway, I wanted to quickly mention, I started working with the Industry University Cooperative Research Centers program back in 2004 as a student. And at the time, they had this really cool practice. They would do annual meetings where all these center leaders would get together in DC and just share best practices and learnings and everything else. And they kept that in place until I think 2015. And they dropped that for budget reasons, I think. But, instead of having dozens of isolated centers across the country, you had a community of academics who are learning how to collaborate better with industry. And it was such a energetic experience to go to those meetings. And I wanted to mention they are starting those back up in some form. They're actually now doing quarterly virtual meetings where PIs get together via Zoom call, and a few centers will share some best practices. And they had one last week. I missed last week. It was about how to better engage with industry members during COVID and virtual meetings. But a colleague of mine went to that last week, and she said it was a lot of interaction. There's a lot of chat happening on Zoom. Directors were interacting with each other, asking questions, learning from each other. So I'm excited that those are starting back up. They're going to do these quarterly. So if the directors at C2SHiP missed last week, much like I did, I will try to go next quarter. I will keep an eye out for those communications and share those with the directors here. And I'm excited to see those starting back up.
Actually, Drew, Marge and I were there.
Oh, good, good.
Yes, yes. So it was good. Next time I will really send out all the emails when they come back again quarterly. Yeah.
Good.
Yeah, I did think it was good. And I think actually Janet and Bijan and Chiara could have been there on the panel talking about what we did in the hybrid meeting at Caltech in December. Because I think we had a really good experience in being able to address the challenges of COVID.
Indeed, indeed. Thank you so much, Drew, for sharing this. So with further ado, I have a great pleasure to introduce our speaker today. Last week, we had a great presentation from industry, from Smart Tech 21 that talk about how we can use metaverse virtual assistant to provide care out of the hospital. And now we are hearing from a clinician who coming from Australia and see the problem about the problem that we have and challenges that we have in the care. So I'm seeing that some need to mute their microphone, please. So, and this is actually Dr. Malindu Fernando, who is a physician scientist, podiatrist, and postdoctoral research fellow at the Queensland Research Centre for Peripheral Vascular Disease, James Cook University, Australia. He was awarded a prestigious Fulbright scholarship to spend some time at ICAM, my team at Baylor College of Medicine, as well as Keck School of Medicine at University of Southern California with David Armstrong. It's very nice, actually, again, a partnership of centers with C2SHiP. So maybe this is one of the fruits of this C2SHiP to, again, opening the opportunity for the scholars to benefit from the infrastructure that we have. He's collaborating on a remotely delivered prevention program for diabetes-related lower limb complication. Mal completed his PhD in 2017 on the biomechanics of diabetic foot, and his postdoctoral work is focused on remote monitoring of risk factors at the risk fit. With that introduction, Mal, we are looking forward to your talk.
Thank you very much, Bijan, and greetings from sunny California. I've enjoyed joining C2SHiP over the last few weeks and really enjoyed the breadth and depth of different presentations and presenters. So it's my pleasure to offer a slightly clinical spin on things, and particularly focusing on some of the outcomes that we're really interested in as doctors or physicians in this area. And I have the pleasure of presenting on a meta-analysis that was very recently published, in fact, last week. So this is some hot off the press material. And just to make sure you can all see my screen there, Bijan.
Yes, we can see that.
Fantastic.
Looks great, man.
Excellent. All right. I want to begin by making a few acknowledgements. I've got no conflicts of interest to disclose. I want to make a special mention of my mentor in Australia, Professor Jonathan Golledge, vascular surgeon academic who's mentored me for many years now, and also make an acknowledgement of my new mentors, Professor David Armstrong and Professor Najafi, and their teams at ICAMP and at Keck for having me here in the United States. I'm really enjoying my time here, and it's been great to spend some time here. So thank you both for having me here. I'd also like to acknowledge the Australian American Fulbright Association for my scholarship to be able to come over with my family and spend some time here, and the funding organizations that supported this work are listed on the screen there. Now, most recently, when you start seeing a graph or figure like this, you're probably thinking, oh no, here we go, this is pandemic numbers again. But unfortunately, here, I'm not actually presenting on anything related to the pandemic, but something else that's been happening over the last 2 decades, really, when you look at the data. And this is a representation of how many people are living with diabetes worldwide. You can see in the year 2021, there's a staggering increase from previous data, and this is just a steady climb of number of people that are developing diabetes globally. When you look at the global data, you can see that there's nowhere on the planet that's unaffected by this global pandemic. And actually what we are now seeing is a resurgence of diabetes complications worldwide. And the early predictions that were made by the International Diabetes Federation have now been revised. It's expected up to 783 million people will have diabetes by the year 2045. And along with this, all the complications that go with it, which is going to cause a massive impact on our health systems globally. But interestingly, when you look at the overall disability of medical conditions and what really carries the burden to a health system and to an individual, it's interesting that work done by Peter Lazzarini and David Armstrong and others have been able to show that diabetes-related lower extremity complications now rank in the top 10 global causes of disability. And what do I mean by this? Well, these are folks that have developed peripheral limb complications, peripheral neuropathy, peripheral artery disease, chronic wounds and amputations. And the burden from these conditions far outweigh many of the other burdens that we see in terms of causing global disability. So this is a major concern. But when we look at the population of people with diabetes, what we're really interested in is to understand how we can try and prevent complications from happening in the first place, but also to intensively treat people working collaboratively to try and prevent further deterioration of their health. And we know that in diabetes that both macro and microvascular complications occur. This is to do with macrovascular disease, that's cardiovascular disease, strokes and peripheral artery disease, or microvascular disease, which is retinopathy, nephropathy, or neuropathy. So the risk factors that lead to these conditions are actually quite common and shared amongst the population with diabetes. But actually, when you look at the burden and what's causing the mortality and morbidity in this population, you can see that cardiovascular disease in the form of MACE, or major adverse cardiovascular events, seen and described there, as well as major adverse limb events, or known as MALE, contribute much of the burden in this population. And you can see the figures there. 1 in 10 did not know about cardiovascular disease and its associated risk factors. 9 in 10 had 1 or more cardiovascular risk factors. 1 in 4 considered themselves to be at no or low risk of cardiovascular disease. And 1 in 5 have already experienced a cardiovascular event. So this is a major concern, and better understanding how we can prevent these complications from happening, but also treating these complications is really important. Some data out of the UK demonstrated here shows all the key modifiable risk factors that lead to this burden of disease in this population. And if you look at the key factors here, you can see that high cholesterol or dyslipidemia, high blood pressure or hypertension, and diabetes or hyperglycemia constitute majority of the risk factors in this population, in addition to all the other modifiable risk factors that are seen there. So really, if you can intensively control these risk factors, you would think that you can try and prevent complications from happening. Well, is that necessarily the case? Well, we've now got over 3 or 4 decades of data to support the management of these risk factors in people with diabetes. So trials done in the early 90s showed that every 1% increase in HbA1c constitutes a much large risk in terms of relative risk of developing microvascular disease. But it was shown that if you could intensively control hyperglycemia in the form of controlling HbA1c, you can see a treatment benefit up to 20 years of follow-up. So people that had intensive treatment of their hyperglycemia were seeing benefits even 20 years later. But this was with the caveat that you couldn't too intensively control blood sugars because you risk people getting hypoglycemic episodes. It has to be done in a very careful way. So we know that from this data that yes, you can control hyperglycemia. Similarly, when you look at lipid lowering or high cholesterol lowering, we now know that LDL is causal of atherosclerosis, which precedes many of these cardiovascular events. And findings from Mendelian randomization studies, prospective cohort studies, and RCTs all say the same thing, that if you can reduce your cholesterol levels, that your risk of cardiovascular disease and cardiovascular events are much lowered. And you can see here a plot that shows this quite nicely in both men and women, that when you intensively control the lipid levels, specifically the LDL cholesterol levels, the MACE or major adverse cardiovascular events are much reduced in this population. And lastly, on blood pressure, well, hypertension management is one of the mainstays of managing these risk factors. So you can see here in the plot between men and women that when you intensively control blood pressure, this leads to a marked reduction in cardiovascular associated mortality in people. So we know that intensively controlling these risk factors is the way to go. And there's a plethora of evidence from high quality clinical trials to really support this. Then you're probably thinking, well, yes, this is all interesting, Mel, but then why are you talking about this? So the question is, are our treatments actually working to try and control these risk factors? And the answer to that is, well, it's actually not, because there's a paper published in the New England Journal of Medicine, which is a National Health and Nutrition Examination Survey, which is a long-standing survey of people with diabetes in the United States. And interestingly, in the most recent data from this survey, they were able to show that there is a decrease in people that are actually utilizing medications to treat these risk factors, despite there being such high-level evidence to try and control these risks. So if we look at these figures here, you can see in terms of glucose-lowering medication over the year period from 99 to 2008, use of blood pressure medication from 99 to 2008, and lipid-lowering medication in the same period, you can see there's a plateauing off of the number of people that are actually utilizing this medication. The conclusion from these authors was there's probably actually a decline in the number of people that are taking the appropriate prescribed medications to manage these risk factors, but I think there's most likely a plateauing off. But what was really staggering to me is that if you look at these three key main risk factors that we know contribute to so much of the burden, that only 22% of people were actually receiving intensive therapy for the simultaneous management of all three risk factors at the same time. So that's a very low number when you look at the number of people that should be on these medications compared to who's actually taking it at the same time. Well, the other aspect to all this is if we are able to control risk factors adequately, the whole idea is about trying to prevent hospitalization, trying to prevent burden on our health systems. But the thing is that that burden has not decreased at all. In fact, in 2015, people with diabetes age 45 or older made an estimated 12 million ED department visits here in the United States. That's a staggering number. And in Australia, in the same period, the rate of hospitalizations for diabetes complications increased by 7%. So more and more people are ending up in hospital because of diabetes complications. And we've created a very complicated health system for folks to navigate. So on average, a person with diabetic lower limb complications has about 5 or 6 specialists looking after them, that being the endocrinologist, the cardiologist, the vascular surgeon, podiatrists, and so on and so forth, the nephrologist. And that's not including all the allied health and other disciplines that are involved in their care. And quite often, the left hand doesn't talk to the right hand, and there's a lot of miscommunication. And especially in Australia, the burden is then placed on the primary healthcare provider to try and navigate this whole complex system for the patient. And quite often they don't have the time or the resources to manage these risk factors adequately and to ensure that a patient is on the treatment that they should be on. And what's more, there's also polypharmacy and other factors that contributes to the burden and the individual burden that a person carries. So we really need to think about the individual and how we can empower the individual to better understand their risk factors and to be able to better manage it. But what's really interesting within Australia, and this has been shown globally as well, is that actually the risk of being admitted to hospital with the diabetes complications was about 12 times higher in a regional area compared to a metropolitan area. And also people living in the low socioeconomic strata were much more likely to be admitted because of diabetes complications. So you can see on the map here, age and sex standardized rates of admissions per 100,000 population. You can see the further you go out from the main city areas, there's much higher risk of hospitalization due to diabetes complications. So people living in the regional and remote areas are really struggling with managing their diabetes. So where is the problem in all of this? Is it the fact that a person's not taking the medication that they should be taking? Well, some doctors may say that. But interestingly, the WHO in 2003 came out with a really interesting concept. And this is a concept focused on adherence to long-term treatments in treating chronic disease. And they were able to say that actually poor adherence probably contributes the principal cause of the development and progression of diabetes complications. And once you've got these risk factors, there's an increase in 2 to 3.5 times of the actual cost of managing people in hospital with these complications. And we know that cardiovascular disease and also limb-related events contribute the largest proportion of all the risk and cost association in managing these conditions within the hospital system. But when you look at what's really leading to poor adherence in this population, we can't blame the patient because it's not as simple as that. Using this diagram illustrated by the WHO, we can see that this is a multimodal issue. There's health system factors, there's condition-related factors, patient-related factors, therapy-related factors, and social economic factors that contribute to why people aren't on the appropriate treatment they should be on. And my personal opinion is, most importantly, is to do with the person really being in charge of their own health, or us advocating for the person to be in charge of their own health. So the question is, does our current model of treating people really allow the person to do that? Well, in a paper we published in Census just a couple of years ago, we illustrated the spectrum of standard care that people with diabetes receive in terms of managing their risk factors for lower limb complications and their overall risk of complications from diabetes. So currently, folks would go for clinical assessment to an outpatient clinic or inpatient clinic, and the physician or a nurse would look at their blood pressure, glucose, lipids. They get prescribed medications. There's clinician education, which may or may not happen depending on the time that's available in terms of educating the individual about the risk factors. There's other organizations that may be involved with that. And in terms of foot assessments, there's in-person assessment of the feet, in-person assessment of offloading and footwear for the individual, and then the patient reports on their offloading adherence, whether they're wearing the appropriate footwear that's been prescribed to them. But is there another approach? Well, in line with the vision of C2SHiP, thankfully there is another approach, and that's a spectrum of remote management. So we proposed in this paper that for people with diabetic lower limb complications, that using remote monitoring of blood pressure, glucose, and lipids, remote consultation on medication, and remote monitoring of risk factors, including lower limb risk factors, and remote assessment of partner pressure and offloading, can actually have a huge benefit to the individual and to the health system. Now, there's already some fantastic work being done by C2SHiP and its members in terms of foot monitoring and remote assessment of lower limb and partner pressure monitoring. But the aspect that was less clear to us was the aspect on remote monitoring of medical risk factors and whether this really has any positive impact on outcomes. So with that in mind, the focus of our meta-analysis that's now published in Frontiers in Endocrinology was really to look at the effectiveness of remotely delivered interventions to simultaneously optimize the management of high blood pressure, high glucose, and dyslipidemia in people with diabetes. So you can see the full text publication for yourselves later, and I'm going to be presenting on the key findings from this systematic review and meta-analysis, which I think will inform some of the research and innovation that's being performed at the moment. So the background to this really is that remotely delivered risk factor management programs have been proposed to have a benefit or to be more efficient way to control multiple risk factors, but there's been no high quality meta-analysis or pooling of results from studies to really look at this, the benefit of simultaneous management of these three key risk factors in people with diabetes. So that was really the aim of our study here. We used a PRISMA compliant method to do this meta-analysis. It was registered in Prospero, and we searched a number of different databases to try and put together all the randomized controlled trials published from 2000 all the way through to 2021. What were we interested in? We were interested in randomized controlled trials that evaluate the effect of remote medical management interventions compared to standard or usual care. The population were people aged more than 18 with either type 1 or type 2 diabetes, irrespective of their disease duration or any history of cardiovascular disease. The interventions we were interested in were remotely delivered healthcare, so this being either internet-based modalities, video conference-based modalities, phone-based modalities, or telehealth approaches. But the key thing was that the controlled trial had to address all three risk factors at the same time, and it couldn't just be one of those risk factors. And the rationale for this is that we know from previous data that unless you control all three risk factors intensively, you can't manage most of the complications in this population. The control group received usual medical management without any remotely delivered healthcare. In terms of outcomes that we were interested in, it was really to do with those three risk factors that I spoke to you about earlier. It was hemoglobin A1C or HbA1C, which is done every 3 months to 6 months in the population with diabetes, total cholesterol and low density lipoprotein cholesterol or LDL, systolic and diastolic blood pressure. We looked at a whole range of different secondary outcomes that are all listed there. This included adverse outcomes from the treatment that was received, major adverse cardiovascular events, major adverse limb events, and any development or progression of micro and macrovascular complications. The other aspect we were really interested in was health-related quality of life in people with diabetes, as well as a cost-benefit analysis. Now, I told you that we included anyone with a diagnosis of diabetes in this meta-analysis and review, but we were specifically interested in one subgroup. And that subgroup were folks that were at a high risk of developing these complications, and in fact, may have already experienced some of these complications that I spoke to you about. So we defined our high risk group as people with a documented history of cardiovascular disease, a diabetes duration of greater than 10 years, an HbA1c of more than 10% at entry, an LDL of more than 2, systolic blood pressure of more than 130 or a diastolic of more than 80, or a previous history of any diabetes-related complications at entry. So this was our definition of what a high-risk group was in terms of carrying out our analysis. We were also interested in really deciphering, in terms of remote management, which aspects of remote management were really crucial to having an effect on these risk factors. So what we tried to do at an aggregate level by pulling all the results was to look at 5 key areas. And this was remotely delivered patient education, remotely delivered monitoring of risk factors, remotely delivered coaching to improve risk factor control. So based on the risk factors that were assessed remotely using portable blood pressure, using glucometers that could transmit data, then providing coaching or behavior modification remotely based on that data. Number 4, healthcare professional telehealth consultations. And lastly, remote pharmacological management. Now, this wasn't posting out medications to people in terms of remote pharmacological management. This was more to do with how a remote team could get involved with the patient-physician interaction and provide guidance in terms of what treatment algorithms could be utilized to optimize care, or where there was a interaction between the patient and a remote team in terms of medication alerts or other types of reminders to the patient to adhere to their treatment. So these were the 5 key areas that we were really interested in. So I'll just get straight on to the results now. So we searched all the literature to identify studies that meet our criteria for inclusion in this review. And we came up with 46 randomized controlled trials initially, and then 27 of those actually met the criteria for inclusion. The reason why most studies were excluded was that they didn't simultaneously address all 3 risk factors, which we believed was really key to addressing the issue of preventing complications. So we had a total of 9,153 participants, and this was randomized to these trials. And then eventually we ended up with 4,581 that completed remote management and 4,519 that underwent conventional treatment at follow-up. This is just a bit of a summary of the types of studies that were included. So we had a range of different countries represented in the 27 clinical trials. We had different types of designs within the randomized controlled trial overarching group. We had different types of technologies that we used, ranging from telephone-based education to practice nurse-led telephone coaching, to web systems that were developed, and to mobile health solutions. And you can see here that also the follow-up durations ranged in these studies as well. So just to give you an overview, the sample sizes from each individual trial range from 36 up to 1,665 participants, and a range of developing and developed countries were included. The follow-up durations range from anywhere from 3 to 60 months. And a majority of studies actually reported on people with type 2 diabetes, and 6 RCTs included people with type 1 diabetes. Unfortunately, most trials excluded people with severe complications such as foot ulcers, progressive nephropathy or kidney disease, or retinopathy or eye disease. 3 studies recruited participants deemed to be at high risk of diabetes complications based on our criteria. So only 3 out of 27 included folks that we deemed to be at high risk of complications. So what was the breakdown of the types of interventions? Well, there were 14 controlled trials that used the telephone modality or telephone-based approach to management. This could be a nurse-led approach or a participant-led approach where they could have a phone communication available that they could contact a remote team to receive ongoing assistance and care. There were 4 RCTs that looked at text message or mHealth-based solutions, and 2 of those RCTs also used a web portal for collecting remote risk factor data. Video conference feedback or education was assessed in 3 clinical trials, and web-based systems were assessed in 9 controlled trials. But some of these web-based systems were combined with text messages or combined with video conference and phone reminders. One RCT actually used a smartphone app entirely to deliver the entirety of its intervention, and one included both health professionals and patient interventions in the one remotely delivered program of care. Now, when you get down to the bottom of what was actually done remotely, it's really interesting to look at how the different studies and clinical trials approach this. In the remotely delivered intervention group, this was a mixed group when it came to biochemistry and how venipuncture was performed. Some folks received in-home sampling, others came into the clinic for their sampling, and other trials used electronic medical records to identify their biochemistry. And there was a few that didn't report how this was collected. Whereas in the standard care, this was all based on clinic-based sampling or electronic patient records. In terms of blood pressure measurement, some of the remotely delivered assessment used physician-measured blood pressure during routine visits. Some people provided in-home measurement of blood pressure using a remote device, and some didn't report it. Whereas the standard care group received very much office-based blood pressure monitoring. When it came to patient education, 20 RCTs or clinical trials used remote delivery methods. The standard care group only got standard care, and some may have received printed material in various studies. In terms of remote monitoring, 19 RCTs provided remote risk factor monitoring technology for participants. 9 used an online interactive risk management system. 4 used wireless data transmission of blood pressure and blood sugar levels. And 1 used a web-based feedback system based on the data that was captured to provide real-time alerts and feedback to the patients. Standard care, once again, was typically regular primary care or physician management of risk factors. And 10 RCTs actually didn't define what standard care was that the control group received. In terms of coaching, consultation on behavior and pharmacology, 22 RCTs provided remote coaching on risk factors, 12 provided remote consultations, and 14 provided remote pharmacological advice or reminders to the patient or to the treatment team in the event of one trial. Whereas the standard care group just received standard care. In 1 RCT, they sent reminder text messages, but these were just greetings. So this wasn't a health-based approach to sending text messages in the control group. Now, in terms of assessing risk of bias of the studies that were included, 12 trials were deemed to be at high risk of bias. 12 trials had some concerns regarding their risk of bias, and 3 were at low risk of bias using the ROB2 tool, which is recommended by a Cochrane collaboration for assessing risk of bias in clinical trials. In terms of excluding these studies from the analysis for high risk of bias studies, this changed the outcome in terms of systolic blood pressure and total cholesterol, but not by much. So I had to mention that at the forefront to folks listening on. We looked at funnel plots as well to look at publication bias in this area. And it was very clearly obvious that negative studies were much underreported in this area. So the funnel plots we were looking at were asymmetrical, indicating that there is published bias in this area, and positive results are more likely to be published than negative results. All right, now get to the crux of what we really found. In terms of a reduction in HbA1c, was remote management actually more effective than standard care at reducing HbA1c? Well, yes. We found that when pulling the evidence from these RCTs that there was a standardized mean difference of minus 0.25, with some reasonable confidence limits there, but a moderate degree of heterogeneity when combining these trials together, that showed that yes, you can actually further reduce HbA1c, although by a moderate degree or in this population by using remote care on top of standard care. In terms of cholesterol or dyslipidemia management, this was the same deal. You could reduce LDL, you could reduce total cholesterol, although with smaller effect sizes when using remote care compared to standard care. And this was seen in the forest plots shown here for LDL and total cholesterol. And likewise, when it came to reduction of blood pressure, we once again showed that both diastolic and systolic blood pressure could be managed effectively and further reduced in remotely delivered care compared to standard care, although this was a marginal effect size when you're really comparing the data. So you have to remember that these benefits that we are seeing is on top of any prescribed medication and standard care that the patient is receiving. So this is really, really interesting that when combining the data from controlled trials, we're seeing some beneficial effects in terms of controlling these risk factors. But you're probably wondering, well, that's great. That's a really good outcome. But what was it about the remote care that actually led to these outcomes? So what we wanted to do in our subgroup analysis, as I showed you, was to look at each individual component of remote delivered care in terms of what the outcomes were from these types of interventions. I'm just going to simplify this diagram for you. So on the left-hand side here, you can see each of the risk factors: HbA1c, total cholesterol, LDL cholesterol, systolic blood pressure, and diastolic blood pressure. And across here, you can see the 5 different types of modalities that we used. You can see when it came to HbA1c, patient education was effective. Total cholesterol, not so much. LDL, yes. Systolic blood pressure, yes. Diastolic, not so much. Remote monitoring of risk factors, HbA1c reduction was highly effective. Cholesterol, not so much at all. Systolic blood pressure, diastolic blood pressure was effective. Coaching regarding risk factor monitoring was really effective for HbA1c reduction and total cholesterol, as well as blood pressure, but not so much for LDL. Consultation, you can see here, was effective for HbA1c and dyslipidemia management, but not total cholesterol and not diastolic blood pressure. Interestingly, pharmacological management was effective for all modalities besides total cholesterol. But the caveat here is that when you looked at the high-risk group that were at high risk of complications, the only significant finding we saw was the impact on reduction in HbA1c. There's either insufficient data for the other risk factors, or it was found to be not effective in a high-risk population when we're using remote care to deliver risk factor management in terms in comparison to conventional care. We also looked at secondary outcomes in terms of adverse events, as I spoke to you about. Unfortunately, very little studies reported on these outcomes. None of the studies undertook a cost-benefit analysis, and quality of life data was reported in 7 RCTs, but could not be combined in meta-analysis. In terms of adverse outcomes, though, when we pull the data together, there was no effect on overall adverse outcomes of using remote care compared to standard care in terms of overall adverse events, as well as mortality, hypoglycemic episodes, or hospitalization. So this was really reassuring. So the secondary outcome data was limited, but showing some promise in terms of adverse outcomes. So what are the caveats of this analysis? Well, you have to remember the generalizability of these findings need to be considered in the population study. And most of these people were people that already didn't have the development of these risk factors or had poor medical management to begin with. And you have to remember that this was an aggregate analysis. We didn't have individual participant data. It's also likely that not all populations are able to engage with remote delivered healthcare. So we really have to look at this area further and work with patients and other industry and healthcare delivery services on understanding how we can deliver care much better. Cost benefit still has not been done in this area, and this is an area that's really important for prospective clinical trials. And key factors such as technology burden, impact on quality of life needs further evaluation in prospective studies. So really, we need to make an improvement on the design of clinical trials, and I believe this is achievable with industry research, patient, clinician collaboration, such as what is happening with C2SHiP. So I'm really excited about the prospect of improving how trials are carried out in this area to really look at the hard endpoints that people are really interested in. So I'm really excited at this concept of moving away from hospital-based care and offering an alternate solution to people in their home environment, in their living environment. So a shift in the way we deliver and improve care. And we've estimated in Australia, just a humble 20% reduction in diabetes complications can have a staggering impact on the annual outcomes. 6,000 less hospitalizations, 1,000 less amputations, $400 million in less in healthcare costs, and 400 deaths avoided if we can remotely do this. But in order to do this, we need to partner with industry, we need to partner with other research organizations. And this is my plug for Australia. So Australia is really a fantastic place to carry out some of this work in terms of clinical trials. And we've got the setup and the resources available there, the geography, the medical system, lower costs, and the scalability to be able to do these trials in partnership with the United States. So we're really interested in collaboration with other groups and industry and health services to improve outcomes for our patients. So in conclusion, the meta-analysis suggests that remotely managing modifiable risk factors, specifically HbA1c, total cholesterol, LDL cholesterol, systolic and diastolic blood pressure is effective. Patient coaching, provision of pharmacological management, and remote risk factor management were identified as the most effective interventions, but further research is needed to rigorously clarify the most effective components of remote management, and heterogeneity and potential publication bias may limit the applicability of the findings. And with that, I'll conclude my presentation. Thank you.
Excellent job, Ma. It's amazing. So it's great. And always I'm saying that when we are talking about translational research, often we think that translational research means translating the research from bench to bedside. But I believe that is bi-directional. It's really the people like you that also can see the problem on clinical side and also bringing those problems to bench to solve them. And you elegantly actually showing some of those problems that actually can be solved by remote patient monitoring. You touch about some of the challenges. Sometimes we are seeing that intervention is very easy. When we talk to engineers about remote patient monitoring, they think that should be fancy, I don't know, metaverse, avatars to coach patient, but sometimes a text message, it could be as effective as those kind of the aspect. And I would like to a little elaborate on these and maybe hearing from industrial side that despite of this huge problem and a great actually impact on the cost saving, why industry didn't investing on this area? And I'm guessing that Martin is on the call, and last week he explaining the amazing virtual assistant device that they are designing to manage post-hospital care. So Martin, what do you think from industry side? Why industry so far didn't tackle the problem of diabetes problem? And do you think that that can be happen with some of those results that are coming, that the remote patient monitoring and some assistant education can be helpful? So I don't know, Martin, are you on the call? Oh, it seems that we lost Martin. So in meantime, maybe we can go to some of the great questions that are coming through the chat box. Ram mentioned that amazing talk, man. When we are doing remote patient management, can you comment about optimal time frame for follow-up with the patients? For instance, patients should be contacted weekly. Should physician get weekly or monthly report? So in other words, how much we should interact with patient, whether we can cause fatigue or not, or if we are not providing enough communication, maybe they might be disengaged as a part of the care.
Thank you, Ram, for bringing this up. This is a really important concept when you're designing studies. So in terms of answering the ideal follow-up, I think if you're doing a study on risk factor monitoring, I think you need to have a minimum follow-up that allows for a period of observation that's meaningful in terms of seeing an effect on HbA1c, cholesterol, and blood pressure. So I think using a number of weeks is probably not quite enough follow-up in this regard. But in terms of the actual interaction with an individual, I think this needs to be individualized. So you'll find different groups of people that require different intensity of interaction. Some folks may only require very little interaction and they'll go off and they're happy to utilize the remote technology. Others may need a lot more. So I think this is really an important area that we need to work further on developing ways that we can individualize care specifically to that individual.
Excellent answer. So I would like to also a little ask about the format of the acceptability by the patient. I was wondering that whether in this study there is any evaluation that what kind of form of communication patient prefer, whether they prefer text or they prefer video, or what's the best engagement with this patient?
So once again, Bijan, that's a really interesting topic as well. And this wasn't very well explored in most of the controlled trials, actually. But it seemed to be that a majority of people engaged with text message-based modalities or mHealth-based modalities much more than they did with video conference or those kinds of modalities. And participants were actually more interested in receiving remote coaching from their healthcare providers or other people as opposed to really telehealth consultations or any other form of intervention. So this area is not very well explored at all. And my personal opinion is that you, once again, have to tailor it to the individual. So using a video-based approach for everyone may not be suitable. Using an mHealth approach for everyone may not be suitable. So it's about understanding what the needs of the patient population is actually. And we've done a little bit of work in Australia, working with patients and healthcare providers to better understand what the best modes of delivery are to deliver this kind of care.
Great. I remember Margaret in a couple of sessions say that even the type of the communication depends maybe some of the ethnicity factor, and some minority may prefer one over the other one. Margaret, do you want to elaborate on this one? I know that you have also a question to ask.
I have so much time, I'm going to need a session with you and try to connect. In fact, Silver Fern is a company out of, I think, New Zealand that I want to invite. They're the only ones I've seen, and I wonder if anybody looked at the psychological, the mental health. So Time Magazine, was it 2 Sundays ago, had a cover story about the psychiatric needs of diabetic patients, but I think they kind of missed it a little bit because we refer to it as the diabetic fog. Dr. Armstrong, you know, at the diabetic limb salvage for many years now, at that conference, we've talked about the diabetic fog, which over the years of going into 1,000+ patients' homes, I've noticed that there's an inability to process. And part of it, Silver Fern has identified through RCTs and research that it is being overwhelmed with the disease. It is a complex disease. The language we use is important. Patients are, you know, it's a difficult thing to explain to somebody in plain vernacular how to manage. So I love the idea of the remote monitoring because they can't process the amount of information needed, it will really help. And as you were saying, Bijan, if they don't have access to broadband, if they can't afford broadband, it's going to be much more difficult for them to be connected with and you know, dialogue. So there's a company here on 8th Street that has done a magnificent job of teaching their clinicians to speak in the vernacular to their patients. So there's a whole host of things that will have to go. Access being one of the biggest ones, the social determinants of health will absolutely drive how those patients will respond and what methodology of communication is going to be advantageous for them.
Excellent point that you mentioned. Actually, this is what we observe in some of our telemedicine. We realize that patients, they have very limited data actually plan, and they don't want to use this data plan for clinical care. And that's a big problem. Actually, we needed to shift also some of our studies that we give a tablet with cellular to not also use the Wi-Fi of the patient that may use their data plan. Is a huge aspect that need to be considered. You mentioned actually, David Armstrong, actually remember that in 2018, when I interviewed for my first faculty position, David interviewed me and I mentioned that I would like work on wearable technology. And he mentioned that, hey, you know what, we need to have a huge need for develop the remote patient monitoring for diabetic foot and engagement. And I know that, David, you're seeing a big transformation here and you're seeing some great systematic review and many studies that look at for management of diabetes. And I'm seeing that also you are asking about the question about the adoption of the technology. Do you want to elaborate on that question?
Yeah, I think it's really interesting because you just saw David Klonoff answer in almost the opposite way. And David answered in the way that I feel very, obviously, enthusiastic about all of this. That's sort of my waking statement. But I think a lot of clinicians, when they are offered data and information like this, sometimes respond a little bit, and they respond in the way that we often will respond to, say, when someone wants us to switch from, or to use a different electronic medical record. And, the EMRs we've been using have been getting, many of them have been getting worse, not better, over the last few years, because they've been geared not toward communication with patients, with doctors, but with what we euphemistically call charge capture. Now, I'm being overly negative on that. I think some things are improving, but I'm just worried. I'm always worried when I see all this stuff, and Mal just did such a great job. The question I was asking Mal was, are there any ways, kind of best practices that he's been thinking about to try to make this a sweeter pill rather than a bitter pill to swallow for the clinicians to adopt, so they don't just shut off?
This is an excellent question, Prof. Armstrong, and I think I don't have the answer, but I think after talking to many clinicians about this and the burden that could be increased by giving them a whole bunch of data on top of all the things that they're already doing, I think what we need to do is to set up a system where they only receive what they need to know about. So we need some sort of remote team, really, that can utilize the data and be.
So this is it. I mean, the call centers. We've talked about this forever. This sort of thing. The call center to be managing the stuff in the middle, just to send out the key information that the clinician needs to know. If the clinician knows that something's happening in the background, maybe that offers her or him some benefit. I love.
So it's a great discussion. So David, I know that you're driving. I hope to be safe. So we are. There are many questions, man. We look at it, and I will share this with you. But I would like to have it. Another legend in the field, Dr. David Klonow. Actually, he formed Diabetes Science Technology to really advocate the use of technology for management of diabetes. So I'm sure, David, you are very happy to see that actually there are some efforts have been done for management of diabetes. Do you want to comment on this one? And what do you see about that systematic review that maybe impress you or it surprised you?
Well, first, I was impressed by how careful the investigators were to gather all these studies and look at different factors. This was a really good article. It showed me that it's hard to find a group of articles that are all pointing to the same type of intervention. Once you divide it up into different types of interventions and different types of clinicians and different types of patients, you're left with a fairly small number of studies for any one intervention. And then you combine the risk of bias, which I believe was in 24 of 27 cases, plus the duration of follow-up wasn't always very long. So we still have a long ways to go. I would just encourage everybody doing a study to include behavior theory, because if you want to make somebody change their behavior, you've got to think of who they are, the psychology, not just have great software. But I'd also make the point that when you're testing a digital health intervention, consider using block randomization, because when you have the same doctor administer both treatments, it may be that the doctor will be more enthusiastic about the health. They'll spend more time encouraging the patient, telling them how lucky they are to get this treatment. And then when they see the regular patient, it's just sort of business as usual, who cares? But if you do cluster randomization, which puts investigators in blocks, you don't have that problem. So in that case, you're randomizing the investigator rather than randomizing the patient. And I wonder how many of those studies that you looked at used cluster randomization, which to me is the best way to test a behavioral intervention.
I think this is an excellent point, Professor Klonow, and I'm glad you brought it up, because I think it's about minimizing bias in the trials that we're designing. And like you said, reducing the burden on the patient as well as the clinician. and really working collaboratively to come up with these kinds of solutions. Because like you said, the perfect software may be perfect, but it needs to be at the hands of someone that can utilize it to their benefit. So thank you for your comment.
Yeah, I echo that. This is amazing comment. I mean, we wrote several systematic review, and also we didn't think that we need to report that important source of the bias, because when we write systematic review, we need to discuss about all the source of bias, and that is really important aspect to be considered. So we passed the time, but there was a also great question came up. I would like to ask maybe this as a last question, and I promise that Mal, we will transfer this question and we'll share the email of Mal so you can communicate with them. But Stefan asked that, can you comment on how glucose was monitored? And was it all mostly finger sticks, or were continuous glucose monitoring involved? But I believe that that doesn't matter, and maybe some of the outcomes might be related to the type of the device that you use for glucose monitoring.
Yeah, this is a great point that you brought up. I can tell you now that a majority of these studies did not use continuous glucose monitoring in their studies. Most of them were finger prick devices, but devices that could take the measurement and then transmit it remotely. So it's readily available to a clinician or a treating team that's off-site, where they can readily access it. Some trials actually utilized a system where patient was given a device they would measure and then manually enter the data online, creating more work for the patient. So it's a mixed bag of the different types of interventions, but none, as far as I'm aware, utilized continuous glucose monitoring. But there are now other meta-analyses on continuous glucose monitoring showing some very promising results.
Yeah, absolutely. It's very important point that you highlighted. Actually, for information, David Armstrong and I, we plan to soon using continuous glucose monitoring for management of diabetic foot ulcer. We believe that this is very important. Rely just on patient to have single point may not be enough. And we know that that is important for management of the foot ulcer. So stay tuned. And I know that David later on will talk about this event. So we already passed 11. Mal, it's amazing talk. And thank you everyone for the great question and contribution. Next week, we will have a talk about FDA breakthrough. Please attend there. This talk is recorded with permission of Mal. Anybody who is interested to have recorded talk, we will provide them to all the members. And with that, happy Friday. Have a great weekend. Thank you all.